right, good morning. Welcome to In the Trenches with DAC. This morning's topic is CHF. In the course of 10 to 15 minutes, obviously I cannot cover this topic in entirety. I'm going to call this CHF part one. Okay, the first point I want to make, CHF stands for chronic heart failure. It does not stand for congestive heart failure. Okay, so you could have acute heart failure, you could have chronic heart failure, or you could have an acute exacerbation of heart failure. This is the terminology, okay? The next point, you have to understand the pathophysiology. You have to understand what's going on. So theoretically, there are two types of heart failure. Systolic heart failure, which is a pump problem, okay, which is now called heart failure with reduced ejection fraction, and diastolic heart failure, which is a compliance issue, and this is called heart failure with preserved ejection fraction. Okay, these are the two types of heart failure. They're treated a little differently, but you have to understand, and sometimes patients could have a combination. Okay, so we're going to talk about what heart failure actually is. It's the inability of the heart to pump out enough blood to meet the body's needs at a normal wedge pressure. So what does that mean? Either the heart's not contracting, it is not contracting, and you're not getting enough blood pumped out and blood's going back into the lungs. Okay, that's a very basic view of this. It's much more complicated. Or you could have a problem with compliance with filling. And we see this in the elderly. So the heart fills in diastole. And the four stages of filling are rapid filling, slow filling, something called diastasis or diastolic stasis, where nothing happens, and the left atrial kick. And as the heart gets stiffer and the compliance gets worse, you're dependent more on the left atrial kick. The left atrium generates higher pressures and it goes back into the lungs. That's HEP-HEF, okay? HEP-REF is a little different. So let's talk more pathophysiology, and it is key. It is important that you understand this. So let's talk first about acute heart failure. So the patient presents with an acute MI, and for argument's sake, this is a large anterior wall MI. Okay, so a normal stroke volume is 60 to 90 cc's, average about 75 cc's. Okay, and somebody knocks off the proximal LAD lesion, and now they have a stroke volume, say, of 20 cc's with an acute MI. What is going to happen? You have to understand this, okay? You're going to have a release of neurohormones. Now, the next point I want to make is CHF is as much an endocrinologic disease as it is a cardiovascular disease because it involves neurohormones. So basically, you're going to have the sympathetic nervous system, the renin, angiotensin, aldosterone system, okay, and ADH all stimulated because you have decreased effective arterial blood level. Heart's not beating normally. So with the sympathetic nervous system, you have beta and alpha receptors. The beta receptors will increase your heart rate, chronotropism, and they will increase contractility. That's inotropism. The alpha receptors vasoconstrict. They will vasoconstrict arterioles to maintain perfusion pressure and venules. Okay, what vasoconstricting these little veins, they're going to decrease venous capacitance. So you're not going to pool blood in veins. So blood's going to go back into the heart. Okay, but if the heart's weak and it can't accept the blood and blood can't pool in the veins, it's going back into the lungs. Now, the renin-angiotensin-aldosterone system is involved. You have decreased blood flow to the kidney. Renin's released. Okay, renin is going to go to the liver, convert angiotensinogen to angiotensin 1, which is going to go to the lungs, and under angiotensin converting enzyme is going to generate angiotensin 2. This is a potent neurohormone and vasoconstrictor, and it's going to maintain pressure. Okay, it's also going to go to the adrenal gland, the adrenal cortex, zona glomerulosa, and release aldosterone, which is going to cause sodium resorption at the collecting duct. The body senses itself as being dry. But the mechanism with ADH, I want to speak on the least. Okay, with a real low cardiac output, you have ADH released appropriately because of the low effective arterial blood volume, and it could cause some free water resorption at the collecting duct and increase blood volume also. The people sense themselves as being dry. This is what goes on acutely. Acutely, all this is great. Get thumbs up. Okay, chronically, it's bad. Okay, but acutely, this is what happens. Now, I'm talking about systolic heart failure now. So, with systolic heart failure, the two major problems you have to worry about and why people die is progressive heart failure and sudden cardiac death or arrhythmias, VT. Now, these people could have MIs, they could have cardioembolic stroke, they could have DVT and pulmonary embolism, but these are the two reasons why these patients die. And the neurohormones play a role here. So there's a condition, a concept rather, called ventricular remodeling. So for whatever reason, say a patient has a large MI and his EF is now 35%. And he leaves the hospital, AMA, and he's not in any medicines, and he comes back 9 months later on pulmonary edema. Now his EF is 20%, and he didn't have another MI. He probably underwent ventricular remodeling. Okay, so with all these neurohormones, especially norepinephrine and angiotensin 2, you have increased afterload and increased preload upon the heart. And these in themselves cause ventricular remodeling. Okay, and unless you block this, okay, the heart will continue to deteriorate. And there was a landmark paper in 1990, New England Journal of Medicine, called the SAVE trial, which took captopril, which was the first ACE inhibitor, and gave it to patients post-MI with ejection fractions 40% or less. And it showed that the patients who got captopril had an attenuation of remodeling, and they did not really exhibit much change in their ventricular function. A very important concept. Okay, now when you're talking about etiology of heart failure, I want to talk about that. Okay, you could break it into two categories, ischemic and non-ischemic. This is systolic heart failure. So ischemic, this is a large MI, multiple MIs, possibly these conditions called hibernating myocardium, where low-grade ischemia just causes ventricular dysfunction, and a stunned myocardium, which you get temporary stunning of the heart, maybe after revascularization or after an emotional event, and then it recovers. But this is ischemic. Non-ischemic, there are a lot of different causes, and it could be idiopathic, it could be familial, it could be tachycardia related, chronic AFib or something else. It could be high output heart failure due to chronic anemia, like someone with sickle cell, or due to thyrotoxicosis or Paget's disease, or in third world country, thiamine deficiency, which we really don't see here. It could be due to viral myocarditis, and we see this in young people. They may or may not recover. It could be related to alcohol use. It could be postpartum in a certain type of person. Okay, hypertension is a debate whether it does this. If it does it, it's the most common cause of non-ischemic heart failure. They clearly get HEP, and it's debated. Some people think eventually the heart just dilates. So theoretically, heart hypertension should be put on this list. Amyloid, and there's a whole new slew of literature. You know, amyloid initially was classified as a restrictive cardiomyopathy, but you could get systolic dysfunction with this. The same with sarcoid, hemochromatosis. Okay, and there are a slew of other things not as common, like selenium deficiency, Chagas disease due to trypanosomiasis, somebody in South America, adriamycin, a chemo agent. So there's a list of other things, and you would have to go through your mind. And what you're obviously looking for if you're going this route is things that are reversible, tachycardia-induced, alcohol-induced, related to chemotherapy, high output heart failure. These things, you know, sometimes you can treat sarcoid or hemochromatosis. But it's nomenclature, and these are the two big categories. So the next thing I want to talk about, and this is very, very important. EBM, evidence-based medicine. There's no disease that you could use evidence-based medicine on more so than CHF, because there have been so many clinical trials. So the idea is that a drug could sound good, but it doesn't work, or vice versa, and you really need the data. And you know, this data is, you know, over 25 years old, but we use beta blockers to treat heart failure, not acute pulmonary edema. And, you know, when I was training in the early mid-'80s, you know, you didn't give beta blockers to treat heart failure. It didn't make sense because the heart was weak to begin with. Okay, so you have to do the trials, and there's so many trials involved in heart failure that you have to understand them. And even within the last couple of years, this has all evolved, and there are different levels of recommendation, and that I'm going to talk about that in a subsequent video. So when you're treating pulmonary edema, and I'm going to stop at this, the cornerstone, you want to decongest people, and you're going to give them an IV loop diuretic, and usually what you're going to do is give Lasix. Lasix will work at the thick portion of the ascending limb of Henle's loop and prevent resorption of sodium. And it will decongest them. Actually, acutely, it's a venodilator, so these people will feel better before they urinate. And this is usually, provided the patient's not in cardiogenic shock and they can tolerate it, this is usually the first thing that's done. Sometimes with the acute sense of dyspnea, we actually give them morphine sulfate, which decreases the sense of dyspnea. And it's also a venodilator, and it can lower the preload. And sometimes we're going to give them nitrates. There's a whole slew of medications. ACE inhibitors, beta blockers, aldo receptor blockers, neprilysin inhibitors, ARB, SGLT2 inhibitors, digoxin, and others that we need to discuss, but that is beyond the scope of this. That will be on a later YouTube video. So right now we're in the trenches, and we did part 1 of CHF. Thank you.